السلام عليكم جميعا. Dear friends and colleagues, it's really deep pleasure and honor for me to be with you in this wonderful meeting organized by Upper Egypt Diabetes Association in the presence of many experts in the Mina region. Diabetes is one of the fastest growing global health emergencies of the 21st century. I will try to mention some information about the diabetes prevalence in Mina. All of you now know about the situation of the bold increasing rate of diabetes in our region. Unfortunately, the serious situation based on the IDF information, the number of the people with diabetes in Mina region will be increasing by 96% from the 2019 to 2045. Based on the IDF report also, it's estimated 5,050,000 people have diabetes in 2019, projected to reach 630 million by 2030 and 700 million by 2045 across the globe. So 51% increase. Diabetes has reached epidemic level. The region has the highest prevalence of diabetes worldwide. At present, 55 million people are living in Mina. If no action now, by 2045, this figure is expected to rise 108 million. What's the need in the Mina region? So in 2021, people have diabetes or burden is an almost 72 million with diabetes people. With undiagnosed diabetes, 28 million. It's huge. This is diabetes estimated between 20 and 79 years. The prevalence rate of countries like Kuwait, 25%, Bahrain, 11.5%, Pakistan, 30%, Egypt, 20%, Iraq, 9.1%, Lebanon, 9%, Sudan, 19%, Morocco, 9%, Saudi Arabia and Qatar, 19%. So this is a high burden of diabetes. The highest prevalence in Pakistan, 30%, the lowest in Yemen, 5%. So diabetes economic burden of type 2 diabetes in Mina region. So we have direct cost and indirect cost. This direct cost, healthcare expenditure, government, private, plus indirect cost, absenteeism, sick leave, presenteeism, reduced productivity due to disease while at work, premature death. So in Mina region, we have 700 million population. So 60 million of them are people living with diabetes. We lose 60,000 every year. It's a number, it's huge. Now, the economic burden of diabetes in Mina, 2019 in 22 countries. Let us look at the annual economic burden of diabetes amount to $60 billion. So 70% of GDP, 22% public expenditure, 22% private expenditure, 8% absenteeism, 44% presenteeism, and 4% premature mortality. So this is an EMRO classification of MENA countries was adopted into 3 groups, relay on the economic level. The classification were as follow. Group 1, 6 countries: Qatar, Saudi, Emirate, Oman, Egypt, Kuwait, and so 6 countries. The group 2, Tunisia, Lebanon, Libya, Syria, Algeria, Morocco, Jordan, Iran. And the third group, Palestine, Djibouti, Somal, Pakistan, Afghanistan. So let us look at the 3 different groups of countries within the region. The first one is the Gulf countries, and you can see that 6 countries. The burden of them is almost 25 billion. When we go to the group 2, which is 10 countries, the burden is $26 billion, but then group 3 is $7 billion. So you can see the main difference between the 3 groups of countries, which is basically divided based on their GDP and an economic status. So at the slide, in the 22 countries, we have more than 60 million diabetic patients currently living with diabetes, and we have more than 60,000 deaths every year as a result of diabetes. It's a huge. This is the economic burden of diabetes as a percentage per GDP in EMRO in 2019. So we have direct cost and indirect cost in each country. Now, the accessing diabetic medicine and care, what are the major barriers? When doctors delay to start treatment or intensify treatment for diabetes, this phenomenon is known as clinical inertia. So clinical inertia, it's very important because inertia contributes to the development of complication, neuropathy, nephropathy, retinopathy, stroke, cardiovascular, peripheral vascular disease, etc. So to avoid clinical inertia, reassess and modify treatment regularly, 3 to 6 months. We have in our region some difficulties to access to insulin in several countries like Sudan, Jordan, Palestine, Lebanon, Syria, Iran, Afghanistan. Now, slide shows diabetes is a serious problem in Lebanon, especially now, affecting alarming 25% of the total population, 13% adults. This is a new data. Prevalence of diabetes in the global population, 9%. We have lack of accessible and affordable insulin. With the currently financial crisis and destabilization, insulin and many medical supplies have become unavailable or too expensive. Before this crisis, the economic collapse, COVID-19, of course, and Beirut war explosion, Lebanon had an enviable healthcare system. About 80% of Lebanese people with diabetes use insulin pen. Now, 20% use pen and 80% use human insulin NPH. So, our situation now in Lebanon, doctors and nurses, both highly in demand, are leaving the country. We have world-class doctors and nurses, and we are losing them. People who can buy insulin are buying it in increased quantities because they're afraid of the storage. Drive more than an hour outside Beirut to insulin access. People who can afford it are buying the medication on the illegal market or asking friends to send it from other countries. The types of insulin that are available in Lebanon, NPH and regular. Now, few consumers in Lebanon use NPH. Analogs, rapid insulin, that was 20 times more expensive than what normally paid. People have to search a lot of pharmacy in many cities. If they may lucky, they can find 2 or 3 pens, usually only short-acting one. Also, the same problem, we have an access to glucose meter. There are no other advanced devices available, such as continuous glucose monitors or other sensors. But now, in addition to our insulin problem, we have to cope with this shortage of glucose test strips too. How can we control our blood glucose level without them? The solution to improve access, building partnership and multi-sectorial action, increased education of health professionals, improving infrastructure, reducing tax and duties, promoting competition and high-quality generic medicine, differential pricing, good procurement practices, and open access to pricing information. This is a good solution in Pakistan. In Pakistan, you have insulin bank, free insulin. So the IDF disaster committee should benefit from this experience to act in the face of emergency situation. So other type of action to provide quality medical facilities, healthcare and housing on a charitable basis through different projects to set up assist educational institutions to promote education, to set up centers for disabled and handicapped people, to grant scholarships, to create welfare and for the help of families of ailing, create awareness and for disease, especially type 1, provide insulin to non-affording children, establish network of quality medical facilities for standardized diabetes care. Sure, free consultation, insulin vials, benefit glucometer, etc. So we need to access to visit glucometer HbA1c in insulin issue. In Pakistan, based on early intervention during the IMRO meeting, the first barrier is that there is no standardization of care. Access to medication is not uniform. Cold chain of insulin is a problem. Difficulties to access to medicine and care in rural area, cost of insulin, capacity building, lack of training, children with obesity, insurance compliance, silent killer disease, discrimination, stigma, cost of insulin or medicine, access to order the small size, the regulation and taxation. In Egypt, Dr. Hanan Jawish talked about 5 important barriers in the same webinar, IMRO. Absence of pediatric education, both in Egypt and the Mina region also. Some few pediatrists who are Western qualified in the Western countries, and they are working now in the Gulf. Physicians are usually glucose-centric. They are mainly caring about the prescribing drugs to control glycemic state. Time to screen, mostly enough time to care, whether in hospital or in the private sector, to care about the complication, not only the food. They don't have time to screen for complication for early detection and better management, or to follow the implementation to guard against the all complication for patient, 4, there is no government and funding for preventive care, for example, the therapeutic footwear, which is almost by most of the guidelines and most of the implementation is crucial for the patient at risk for ulceration, is not funded yet in our country. Finally, 5, no structure of healthcare referral system as the one present in the developed countries. In Jordan, also Dr. Rifki in the EMRO meeting said last survey, 18% diabetic population will not take their medication. Is it because of the access to the health centers, access to the medication, access to doctor, inertia, and complication, or because they are not interested in taking their medication that are they believe? They have no symptoms, they have no science, herbal medication, and not following doctor's recommendation for treatment, access for education, cost of education is very high in private sector. In Jordan, we have 710 centers, public health, and this isn't that is everybody can access. We have no problem for access to health centers. We have also no problem to access to the medication in the center. So act immediately, if not now, when. Thank you for your attention.